Good evening, everyone. Welcome to the third evening of the CUHK Sarcoma Masterclass 2022. This is our fifth CUHK Sarcoma Masterclass, and I'm Dr. Herbert Long, Associate Professor at the Chinese University of Hong Kong. It gives me great pleasure to be able to host the Sarcoma Masterclass. This is a recurring event, and certainly our day 3 is one of the highlights of our Masterclass, because today we'll be having updates of different research that's been going on in various Asian Sarcoma Consortium institutions. And before we begin, I just want to quickly maybe highlight what we have planned today. And I think mainly the purpose of today is really just for us to catch up in terms of the sarcoma research that's being done in the Asia Pacific region. And hopefully it can sow the seeds for further collaborations as well. So let me share my screen and provide you with some quick overview of today's event. So again, this is the third day or the third session of our CUHK Sarcoma Masterclass. And tonight it will be slightly longer in duration. We've earmarked from 7 p.m. to 9 p.m. tonight, really just to have a deeper dive in terms of some of the research that's been going on in our region. And again, today's session is not a standalone session. The Sarcoma Masterclass itself is a 4-day event. Today is the third day. And for tomorrow, we have the highlights of all our sarcoma sessions being the multidisciplinary case discussions, where we've earmarked 5 different cases from around the Asia Pacific region to be discussed. So please do join us if you have the time. It's from 10:30 to 12:30 Hong Kong time and Singapore time tomorrow. For tonight, though, we actually have 5 speakers from across the Asia Pacific region who will be speaking to us. I would like to introduce them one by one as we go through today's talks. At the same time, though, it's very important for us to note that the Asia Sarcoma Consortium really is a basket of institutions within the Asia Pacific region, extending all the way north up to Japan and Korea, and down south to Singapore as well as Malaysia. So we have been formalized as a consortium for quite a few years now, and certainly I think this would be a good opportunity for us to move forward in terms of some of our collaborative research. A little bit of housekeeping. Certainly with all our sarcoma masterclasses, we always welcome interaction and questions. The sarcoma community is always a close-knit community and a small community. So do feel free to ask your questions either through the Q&A box or the chat box during the session, or certainly during the Q&A sessions or the panel discussion. Do raise your hand and we can unmute your mic, and certainly you can ask your questions directly. So maybe we'll start off first with our first speaker, who is Dr. Valerie Yang from Singapore, who will be providing us a quick update in terms of some of the latest research that's been going on in Singapore. If I could quickly introduce Dr. Yang. Dr. Yang is currently an assistant professor in medical oncology, as well as consultant in the Department of Lymphoma and Sarcoma at National Cancer Center, Singapore. She's jointly appointed at the Institute of Molecular and Cell Biology, A*STAR, where she leads the Translational Precision Oncology Laboratory. She is a National Science Scholar, a graduate of the MB PhD program at the University of Cambridge, and the winner of multiple national grant awards. And most importantly, in terms of her academic accolades, she was an alumni of the CUHK Sarcoma Masterclass in 2018 or 2019. I can't remember, Valerie. Anyways, so that definitely will be the very top accolade in her subsequent CVs. And we always welcome and we're always happy to have our alumni come back and speak to us as a presenter. So Valerie, over to you.
Thank you very much, Herbert. And thank you for the invitation. And thanks for putting together such a wonderful symposium. So, it's indeed an honor to be invited back as an alumni. May I try and share my screen?
Looks good.
Yeah. Okay. Yeah. So in the next few minutes, I just want to share one aspect of our work from Singapore. And, I hope this will be of interest to everyone and perhaps maybe even spark some interesting discussions and maybe some good collaborations. So I just want to say this is our sarcoma team in Singapore today, our 8 sarcoma medical oncologists. And this is what we look like. Our multidisciplinary colleagues are also listed here. So we really have a nice, close-knit family here in Singapore. And just to say that a lot of the clinical and laboratory research that we do really utilizes our well-curated patient database, whose foundations actually have been set by those before us, which we now maintain and continue to improve upon. So in the next 15 minutes, I'd just like to share with you one aspect of the work from our team. So it starts off with a young lady with an aggressive solitary fibrous tumor, or SFT. So as part of her clinical management, we had the opportunity to utilize cells from two separate tumor resections to generate patient-derived cell line models, which we then use for drug testing. So as you know, solitary fibrous tumors are rare soft tissue sarcomas for which therapeutic options are quite limited and ineffective. So we demonstrated how functional precision medicine could be implemented in the clinic for this metastatic SFT through a combined strategy of patient-derived model development as well as some computational drug analytics. So happy to say that she is still doing well. She's 6 years on from her diagnosis, and she's 2.5 years with metastatic disease, and still going strong despite her aggressive disease. So let me first briefly describe the case. So this young female in her late 20s, she has an unremarkable past medical history. She was my patient actually, and one of my first patients when I first qualified as a medical oncologist. So she presented in 2015 to an external hospital with severe headaches. MRI of the brain showed a left lateral ventricular mass with a midline shift. There were no other lesions on PET-CT imaging, and histological evaluation on excision of the mass showed a WHO grade 2 SFT. So she was given post-operative radiation, but this was also interrupted by wound infections. And 4 years later, in 2019, she developed a local recurrence, and she was offered a repeat resection versus radiotherapy, but she opted for expectant management. In 2020, a year later, the lesion continued to grow, and she then underwent a palliative local resection. 6 months later, however, she developed another local recurrence in the brain and also metastatic disease to the liver. And that was when she was first referred to us in medical oncology. So you can see here that she's got a big 10 centimeter liver metastasis. She's got some other smaller lesions in the liver as well. Her CT brain here showing local recurrence. So we commenced palliative liposomal doxorubicin for her given her metastatic disease. But after 2 cycles, her disease continued to show progression in the liver metastases. So the dominant liver lesion here growing from 10 centimeters across to 12 centimeters across with stable disease, thankfully, in the brain. So we discussed it at our multidisciplinary tumor board, and options of palliative surgery, ablative approaches, second-line systemic treatment were all discussed. And the collective decision was for palliative resection of the dominant liver mass because we were worried that her liver function might be becoming impaired. So we took the opportunity to collect fresh sample from this, and we generated models for from the patient and for drug testing. We actually found these cells to be sensitive to pazopanib in vitro, which I'll elaborate upon later. So following resection, we did commence on pazopanib, which is also an accepted second-line option in SFT. And after 2 months, she had mixed response in the liver lesions. So most actually reduced in size. You can see them here. Although there was one other lesion which grew bigger. Her brain lesion also grew slightly bigger, although she remained asymptomatic from this brain lesion. So she was discussed at tumor board again, and she collective decision was for radioembolization to the liver lesions, given the lesions that were growing, as well as to encompass some of the existing lesions. 3 months later, her disease in the liver was stable and she was well, but as you can see, her brain lesion continued growing. So because of the isolated site of progression in the brain with disease control elsewhere, she underwent another round of a palliative craniotomy. She's now about 1.5 years from her last brain operation. And again, cells from this operation were collected to generate models with drug testing. And here we also found that cells from both this brain lesion as well as the liver lesion was actually sensitive to eribulin in vitro, which I will also elaborate upon later. So now we're going to show you what we did with her cells in the lab and how we use this to guide her treatments. And we'll come back to the patient in a while. So these are the respective lesions that we evaluated in the lab. The liver metastasis was resected first and named HSC06. The brain lesion was resected later, the recurrent brain lesion, and named HSC31. H&E staining was from both sides was consistent with SFT. Some arrows which indicate some mitotic figures are also seen. And this, importantly, is STAT6 immunoperoxidase staining, which again is consistent with SFT, as they typically have a NAD2 STAT6 fusion, which results in upregulation of STAT6. So in vitro, you can also see that the cells can proliferate in culture. This is an Elmer blue cell proliferation assay. Cell numbers also increased over time. There was some Ki67 staining showing that cells were actively cycling in a cell cycle. Immunofluorescence of some other markers also with vimentin, CD34, BCL2, ALDH1, STAT6 was also present, suggesting that there's retention of SFT characteristics in these patient-derived cells. And importantly, we tested for the presence of the NAD2 STAT6 fusion gene in these patient-derived lines. And as you can see, it was indeed detected. And this is actually the gold standard for SFT diagnosis. Interestingly, we actually detected the 616 variant. And so this has been reported to occur more frequently in extrathoracic and meningeal SFT, and is also associated with an aggressive clinical phenotype. Again, this is consistent with what we saw clinically in our patients. So now that we've confirmed that the cells we obtained from the patient and growing in the lab were indeed SFT cells, we then used ex vivo drug testing and a platform called CUHK to analyze drug sensitivity and resistance. So let me briefly explain CUHK. CUHK is actually a computational combinatorial drug screening platform developed by our collaborators. And details of this platform actually has been published elsewhere, including in Science Translational Medicine, and applied in the context of multiple myeloma and lymphoma. So CUHK was used to derive and predict the efficacy of drug combinations from a 12-drug panel. And the top panel shows a heat map of CUHK-derived differential drug responses in cells from the liver metastasis. The bottom is that from the brain lesion. And so in the top panel, you can see from the liver metastases, pazopanib was ranked highly for cell kill. In fact, as a single drug, it outranks doxorubicin, which perhaps is also consistent as it corroborates what we saw in the patients with her liver lesions progressing past liposomal doxorubicin. So other possible single agents that can be used in soft tissue sarcoma, like ifosfamide, gemcitabine, and others, ranked lowly. Interestingly, CUHK actually identified that a combination of a BET inhibitor, OTX, and pazopanib far outranked standard of care combination of ifosfamide doxorubicin. You can also see from the response surface maps that pazopanib and OTX show this curved shape, suggesting synergy between the two drugs, whereas the response surface map of doxorubicin and ifosfamide showed no synergy. So on the bottom, this is data from cells of the locally recurrent brain lesion, and on the heat map, you can see that pazopanib is now ranked lowly, again corroborating what we saw in the patient, because the brain lesion was actually growing with pazopanib treatment. And instead, now eribulin ranks higher for predicted cell kill. And once again, other drug combinations outranked ifosfamide doxorubicin combination. So since the CUHK platform was really a prediction of drug response, we also wanted to verify these predictions experimentally by dose response drug sensitivity assays. So here I'm going to show you some work from the cells in the liver lesion. When the BET inhibitor OTX and pazopanib was administered concurrently in the liver lesion cells, there was a marked shift in the dose response curve. The IC50 of the drug combination was decreased compared to when drugs were administered alone. And the FACI quantitative diagnostic plot also shows that the treatment is synergistic. In contrast, when we tested combination of ifosfamide and doxorubicin, IC50 curves showed no synergy, and in fact, you can see that of the three options, perhaps doxorubicin alone was most effective. The combination was in fact antagonistic. So this was interesting to us because it showed that CUHK can actually derive combinations that are more effective than standard of care drug combinations such as ifosfamide doxorubicin. We also looked at targets of OTX and pazopanib on immunofluorescence, which showed that their known drug targets were indeed downregulated, more so with combinatorial treatment than with individual drugs. So then we asked, what might actually account for the synergy between OTX and pazo in cells from the liver lesion? So we looked at differentially expressed genes in cells from single drug and combination. Here is a Venn diagram of the number of differentially expressed genes a volcano plot, and a heat map of differentially expressed genes. So how do we actually find the culprits that might be responsible for drug synergy from all of these differentially expressed genes? So because we found that when given in combination, the IC50 of OTX only saw a moderate reduction, whereas the IC50 of pazopanib was significantly reduced by 80-fold. So this suggested to us that perhaps the efficacy of OTX and pazo combination could be due to increased efficacy of pazopanib in these cells, with OTX somehow rendering pazopanib more effective. So is this indeed really true? So what we did was we specifically looked then at targets of pazopanib and their downstream effector genes to see whether addition of OTX would enhance their change in expression. And indeed, we did find these changes in downstream effector genes. You can see here EGR1, FOS, RGS2 increased in expression, and CCL2, F3 actually decreased in expression. And in fact, the altered expression of all these genes have been associated with an increased susceptibility to apoptosis, suggesting that perhaps the synergistic cell death observed with OTX-pazo combination could be mediated by apoptosis. So it's possible that maybe changes in these targets might be the explanation for synergy seen in OTX-pazo treatment. So the next question we also wanted to ask was, what could possibly account for the difference in pazopanib response in the paired lesion from the same patient? You'll remember that cells from the liver lesion were sensitive to pazopanib, but cells from the brain lesion were actually highly resistant. In fact, in the lab, they were found to be more than 10-fold higher. So again, we did volcano plots and looked at differentially expressed genes. And you can see that UGT1A10, it's very small here, I'm so sorry, was identified to be highly differentially expressed. And when we look further, we found that other members of the UGT1A family also showed the same trend. So they were high in the HSC31 brain lesion compared to the liver lesion, and also showed increased expression upon pazopanib treatment. So then we also decided to look back at the patient tumors. So here we're looking at formalin-fixed, paraffin-embedded sections from the patient's tumors. So this is the brain lesion, HSC31, and this is the liver lesion. And here you can see there's a stark difference even at the protein level now, not just mRNA expression, that can be seen on immunohistochemistry from the patient's tumors. UGT1A was highly expressed in the pazopanib-resistant lesion, but not so much the pazopanib-sensitive one. So could it mean that UGT1A could possibly play a role in mediating resistance to pazopanib in this patient? So now we want to come back to our patient again. And you remember that she actually had a craniotomy because this was the isolated site of progression of the disease at that point. After her last craniotomy, though, her brain lesion recurred again 4 months later, as you'll see here. And in fact, it doubled in size over a month from 1 centimeter across to about 2 centimeters across, while her liver disease remained stable, thankfully. So because she already had a recent palliative brain resection and she was also not keen for radiation, we decided to try some systemic treatment. And because we identified that cells from both the liver and the brain lesion were sensitive to eribulin, we decided to treat our patient with eribulin. Interestingly, she did attain stable disease in the brain. So in fact, the 2 centimeter lesion now went from 2 cm to 1.8 centimeters, when it had previously doubled in size in the previous month. Therefore, halting and gaining some disease control of the lesion in the brain. So given how this was a fairly aggressive tumor that had failed multiple lines of treatment and which was growing fairly rapidly in the brain, as well as how the vast majority of SFTs actually don't show spectacular response to systemic treatment, the arrest of disease progression with eribulin was actually quite good news to us. So just a very quick word on eribulin in SFT. So while eribulin is not actually part of standard of care options in SFT, Dr. Silvia Stacciotti's team in Italy did show some eribulin efficacy in SFT in PDX mouse models, and they're running the phase 2 eribulin and advanced solitary fibrous tumor trial, which is now recruiting. So the response from our patients perhaps also supports the use of eribulin in SFT. So perhaps some conclusions that we can make. So paired patient-derived SFT cells did recapitulate features of our patient's tumors. drug responses in vitro also accurately reflected clinical radiological responses in the patient. The platform CUHK identified drug combinations superior to standard of care combinations such as doxorubicin and ifosfamide. Potential downstream targets of pazopanib perhaps may account for the observed synergistic responses with BET inhibition, but this, however, needs validation. Can UGT1A indeed be a biomarker to predict for pazopanib resistance in this context? Obviously, this needs validation, and more samples need to be tested apart from just this N equals to 1 patient case. Quite meaningfully, CUHK actually accurately predicted for eribulin sensitivity in this patient, which allowed her to achieve meaningful disease control. And happy to say that the patient is still doing very, very well. It's been 6 months since her eribulin treatment, and she still remains of excellent performance status. She's a mother to a 3-year-old young girl, happily married, and is also running a home baking business. So this work is by no means complete, and there are many questions to address, but it's encouraging to see that perhaps, the prediction of disease response could be accurately predicted in the lab, which was actually borne out in the patient. So with that, I just want to thank several people involved in the work. Benjamin Chen, wonderful collaborations with Dr. Edward Chow, PhD student Sharon Chan, Dr. To Tan Boon from the N1 Institute, the SGH pathology team, including Dr. Timothy Tay, Dr. Singyi Wu from the Bioinformatics Institute, our surgical collaborators as well, who very kindly provided tissue, and most of all, of course, our patient. Thank you very much.
Thanks very much, Valerie, for giving us for several points, and one for kicking us off or kicking off our third session, but also really highlighting the where we're at now in terms of personalized medicine for sarcomas. And certainly we have a lot of preclinical models that we can work on. We certainly have a lot of the both lab bench research, as well as I presume a lot of computational research that you've actually also highlighted. And it's good that we've been able to find off-label uses of commonly used drugs, even in sarcomas, for these relatively even rarer sarcomas. I would like to open this up to discussion from the attendees. So certainly if any of the attendees have questions, do type your questions in the Q&A box or raise your hand. At the same time, certainly any of our other speakers or panelists, if you have questions to ask Valerie, this would be a good time. We also have earmarked a short period at the very end of tonight's session for a panel discussion, but if there are any burning questions, we can ask Valerie. And in the meantime, maybe I could just throw one out first. You've shown a very good example of SFT. Would this sort of platform work for essentially all the different types of rarer sarcomas, or are there specific sort of catches or nuances where it may not be possible?
That's a fantastic question. Thank you, Herbert. In fact, we're utilizing the same platform for across a multitude of sarcomas, and we've been doing this now for about probably 2 years now. And it's kind of pretty much dependent upon the tissue that we have available from the cases that we get in Singapore. So at the moment, I think the vast majority of the cases that we've tested tend to be those of liposarcoma, but it really is across the panel. We're actually putting together another manuscript to report our findings from what we have so far. But yeah, it looks like in at least some of the cases, there is a fairly accurate reflection from what we derive from CUHK testing, and also from what we derive from cells from excision of tumors from the patient. So it's not often that we get the privilege, so to speak, to test tumors where we resect them palliatively and do have disease left inside in the patient to test and apply the platform to. So actually a lot of our samples came from localized disease, which were resected. And in Singapore, we commonly don't give adjuvant treatments. So in some cases, we actually haven't had the opportunity to test the platform in these sorts of cases. But in some of the cases where we do have disease left in situ, it does seem encouraging that what is predicted from the platform ex vivo, and again, validated ex vivo as well in the lab, appears to reflect what happens in the patient.
Thanks. I think Tom has a question. Tom.
Yeah, so thank you, Valerie. It's just very wonderful talk, and I think really in rare cancers like sarcoma, it kind of gives us another direction as how do we choose. So I think practicality is that, this definitely takes a lot of resource and time. So what's the expected time when you have these samples collected and to really have these results? And do you have, because you've mentioned that you do have kind of few patients now ongoing, what's kind of successful rate that you're going to have this patient-derived cell line to be able to use for testing? And I think lastly is when you see there definitely possibly there are different responses from like different tumors, how are you going to address that issue? Thank you.
Thank you, Tom. Wonderful, wonderful, fantastic questions. And so to address the first question about sort of turnover time, I suppose. So actually when the cells are actually obtained and we dissociate them and we subject them to the CUHK panel testing, turnaround time is actually quite fast. In 5 days, we can generate a readout, which will basically show you the different combinations and their ranking as compared amongst each other in the 12 drug panel. Okay. I think the other question was about sort of responses in the patient, is that right?
Yeah, the successful rate, actually.
Yeah, so I suppose success rates are determined on a few fronts. So the first front, I suppose, is whether or not you need to be able to have enough viable cells to be able to test this, right? The good thing is we can actually just take resection specimens and dissociated cells without actually having to derive them in culture, so to speak, in order to test them. But we still do in parallel develop patient-derived cell line models as well, because we do use this later on for more characterization downstream. But technically speaking, you don't actually need these derived lines to be able to do the testing. Okay, as to the reflection of how accurate it predicts for sensitivity in the patient, like I mentioned to Herbert earlier on, which was a great question as well, is that I think, with the rarity of sarcomas and also with the fact that we haven't had the opportunity to test that many patients with disease left in situ, the vast majority of patients were resection specimens from localized disease. So we haven't had the chance to test in many of these cases, whether it's truly reflective or not. But for those that we have tested, it does seem to be reflective, and we're quite encouraged by this. So I think it's a bit too early to sort of report success rates, because success rates at the moment are pretty high because of small numbers. But I think as the numbers get bigger, it might go down. Yeah, I hope that answers the question. I don't know if I missed another question.
I think that's the
Yeah.
difference is when you see two organ or like response to drugs.
Yes.
Yeah.
So I don't know that there's a good answer to that question. Absolutely, we do expect to see a heterogeneity between separate lesions in the same patient, as was very borne out here in our SFT patients. So I think we have to be very circumspect as well in terms of applying the results from these testing to the patients. But I think it can still potentially be a very powerful tool, because in situations where we have such rare tumors and very frequently we exhaust standard of care options, and really if there could be some drugs that could be repurposed, which we actually know to be safe, we know what dosing to give our patients. What we don't know really is the efficacy of the drugs in these patients. But commonly a lot of our sarcoma patients are young patients, and they come to us being very fit, but just wanting some sort of systemic treatment. So I think this can still potentially be a very powerful tool. And at the same time, I think it's a good opportunity for us actually in the lab to have the opportunity to systematically screen drugs that could potentially be useful in these patients, especially because of the fact that these are such rare tumors. We don't often have the chance to be able to test many drugs, in many arms in clinical trials. But perhaps these cells derived from the patient might give us a little bit of an insight, which we can then maybe go on to evaluate a little bit more in the lab, and whether there are indeed associated biomarkers that might be linked or correlated to some of the responses that we see in the lab, plus minus in the patients. And perhaps later on, through those means, we can evaluate whether these potential biomarkers might indeed be seen in patient tumors, and perhaps more intelligently design our clinical trials based on more refined biomarker selection, which in a way has been tested in the lab in an ex vivo setting.
Thanks, Valerie. I think Jyoti has a quick question before her talk.
So, my question is actually just related to what you have discussed just last. It is related to heterogeneity. So I wanted to actually ask, when there's a primary and there's a metastasis at different, parts, there is always a possibility that, they will vary the different clones. So how we will choose, and if there are contrasting results, then how this will guide that. That is my,
Thank you, Dr. Bajpai. Again, an excellent question, and I don't think I have a good answer for you, is the truth. But, I think there's so many limitations to this, and the fact that it actually was borne out in the patient is actually really just good fortune, with all the stars aligning, so to speak, because so many different things can go wrong, and for the longest time, we even asked ourselves, how do we know what we're treating in the lab in vitro is actually indeed reflective of what's in the patients? What about tumor evolution? What about ongoing changes? So, the cells are going to evolve differently in the Petri dish compared to how it evolves in the patients. So, a lot of unanswerable questions, and I don't think we can ever answer that question. Perhaps the hope is that if we do indeed have tumors which are not so heterogeneous, perhaps, or, in certain sarcomas where perhaps between primary and metastasis, there isn't so much of a difference. In fact, I think some years ago now, perhaps I think in 2018, there was a paper that I read in clinical cancer research, where they actually looked at leiomyosarcomas and liposarcomas, and they mapped mutations across primary and metastatic disease. So I think what they found was that there's a lot of shared truncal mutations rather than too many novel mutations going from primary to metastatic. So my kind of silent hope for this was that, hopefully sarcomas are not so clever, so to speak, and develop too many mutations, and that they might be silly enough for us to target them in some way. But they're also very, very difficult to target because, them being so rare, it's really quite difficult to apply this across the board to many, many, many different patients and across so many heterogeneous subtypes. So it's a really big challenge, but I think there are certain avenues here which lends sarcoma perhaps to be one of the more useful entities to doing this sort of work, because of the fact that, one, we get a lot of tumor from resections, so there's a lot of cells to play with, and two, I'm hoping, against hope perhaps, that maybe they're not too heterogeneous, and maybe they would still work in some way. So maybe if, say, we do have a patient for whom, the predicted drug that is tested to be sensitive works in one lesion but not the other, perhaps we can still rely upon other techniques to deal with the other lesion that's not responding, whether it's radiation or whether it's palliative surgery. But, if you can get perhaps a little bit of response somewhere, that's still a little bit of benefit over not being able to get response, I suppose. But we will really need, formal clinical trials, prospective clinical trials with long follow-ups and sufficient patients to be able to show, what is truly clinically meaningful, and also looking at things like, survival as well. Yeah.
Thanks, Valerie. I think that really echoes the fact that we really need to collaborate in terms of sarcomas. These are rare diseases, and it's good that we have everybody here seated today, and certainly we'll think of some ideas of how we could collaborate. So we could then circle back to this later on during the panel discussion when we have time.